So today we'll be talking about the diagnostic and interventional radiology part in traumatic injuries of liver, spleen, and pancreas. The outline of today's talk is going to be brief introduction about the armamentarium that we have in trauma. Then the evaluation of the trauma patients based on whether the patient is hemodynamically unstable or stable, followed by diagnostic radiology in abdominal trauma in evaluation of liver, spleen, and then pancreas. And then finally, interventional radiology in trauma. We'll start with the SAR standards of practice recommendations, and then follow it up with a few cases on liver and spleen interventions. And then we'll finally conclude. So coming to the first part of our part of this presentation. So abdominal X-ray in abdominal trauma is not routinely used. It can detect pneumoperitoneum, but in cases of acute abdominal trauma, it is a rarely used investigation. EFAST is a part of the primary survey along with chest and pelvic X-rays, and this plays a significant role in detecting abdominal trauma. In EFAST, we evaluate the 5 P's: the perihepatic, perisplenic, pelvis, pleural, and pericardial cavities for the presence of any bleed or free fluid. Any fluid in the abdomen or pericardial or pleural cavity in a patient of acute abdominal trauma, unless proven otherwise, is considered as hemoperitoneum, and the patient is evaluated accordingly. I also follow additional evaluation of the paracolic gutters, as I find that this increases our sensitivity. It has a significant 15% false negative rate, probably because of the operator dependency. Minimal free fluid may always be present in patients of reproductive age group and in pediatric patients, and this needs to be evaluated with caution and in comparison with the clinical status of the patient also. However, it is not reliable for bleeding into the retroperitoneum or bowel or mesenteric injuries. And as I said, the differentiation between simple free fluid and hemoperitoneum is it's not feasible on ultrasound, and we always consider that it is hemoperitoneum unless proven otherwise. So CT is the main workhorse in evaluating the extent of abdominal trauma. In FAST positive patients, we usually go for a dual phase CT scan with arterial and portal venous phase. And in FAST negative patients, we can a single portal venous phase CT abdomen will suffice. When it comes to interventional radiology, there has been a paradigm shift towards non-operative management of abdominal trauma patients, especially solid organ trauma. And IR is considered as an extension of non-operative management. Most commonly, interventional radiology in trauma is for the purpose of embolization, but there are a few cases where vascular reconstruction with covered stents is also done. MRI has very minimal role in acute abdominal trauma. It is primarily used to evaluate biliary and pancreatic injuries. So the CT protocol has been having revisions in the recent past, and there have been publications from both India and abroad, which talks about the requirement of an arterial phase, the addition of arterial phase in increasing the confidence of picking up vascular injuries in patients with splenic injury. So it is always preferable that whenever the patient is FAST positive, it is better to go for an arterial phase and a portal venous phase and further phases. So in the usually in arterial phase, we cover the chest and abdomen. In the venous phase, just the abdomen. And a further delayed phase, limited sections can be taken in case of suspicion of vascular injury. And an excretory space is taken if there is, if you pick up a renal laceration more than 1 centimeter in depth, or if we are suspecting any ureteric injuries by way of fat stranding around the ureters on the initial venous phase scans. However, an excretory phase filling up the bladder passively is not a substitute for CT cystogram. So whenever there is a suspicion for bladder injury, it is always recommended that the bladder be filled with contrast, which is diluted at a concentration of 10%, and filling the bladder with 300 ml of this solution in cases of suspected bladder injury, and repeating a limited pelvic CT to diagnose the same. Rectal contrast again is used in suspected rectal or colonic injuries or significant pelvic trauma to rule out any rectal or colonic perforations. Oral contrast as of now has no role in acute trauma, and non-contrast has very few indications, such as when CT is performed for patients with poor renal function, just to have a general idea to see if you can pick up some injuries or pneumoperitoneum. And otherwise, in patients who have already undergone a contrast CT previously, in those patients, we need a non-contrast to differentiate between a contrast leak and a fresh bleed. So CT protocol in pregnancy. So pregnant patients with trauma is a difficult combination for everybody, both the surgeons and the radiologists. However, CCT abdomen, including a single phase CCT abdomen, including pelvis, is considered safe in pregnancy in all the trimesters, considering the risk-benefit ratio, and the recommendation of less than 50 milligray exposure is fine. It has shown that there is no detrimental effect on the fetus. A routine single-phase CCT of the abdomen again would have an exposure of just less than 35 milligray, so it is safe. And always it's better to follow the ALARA principle with low dose protocols and automatic exposure control. MRI and MRCP, as we discussed, has very few injuries to look for, at the degree of pancreatic injuries to pick up ductal injuries especially, and for suspected biliary injuries or biliomas. Now coming on to the evaluation and management of the trauma patient, all of these abdominal trauma patients are divided into two groups, whether they are hemodynamically unstable or stable. So in a hemodynamically unstable patient with unresponsive profound hypotension, we do an EFAST and conventional radiographs of the chest and pelvis AP view in supine to look for hemoperitoneural imaging and stabilized with damage control surgery. However, if the patient undergoes successful resuscitation and becomes hemodynamically stable, then we can go for a contrast enhanced CT to identify potential injuries. Once the patient comes out of the operating room and becomes hemodynamically stable, we go for further evaluation with a CECT to pick up other injuries, potential injuries, which can probably be missed in a damage control surgery. When it comes to hemodynamically stable patients, a FAST is done, and then review of the mechanism of injury is done. Let's say there is a non-dangerous mechanism and the patient is FAST negative, and there are no significant findings on X-ray, and non-operative management and observation is the norm. However, whenever there is a dangerous mechanism of injury or when there is FAST positive, we go ahead with a contrast enhanced CT. And here we will prefer a dual phase CT. However, despite having a dangerous mechanism, if the patient is FAST negative and we have a moderate to high index of suspicion, we can go for a contrast enhanced CT, and here a single phase portal venous phase CT would suffice. And then based on the contrast enhanced CT findings, if there are any perforation of hollow viscus or disruption of the pancreas or any major vascular injuries, the patient requires an urgent surgery. However, if there is just acute hemorrhage, parenchymal blush, or solid organ pseudoaneurysms, then the patient can either be taken up for surgery or angiographic embolization, depending on the available facilities. And then isolated organ injuries with stable patients, again, we can go for angiographic embolization or just follow them up with a non-operative management. So coming to the role of diagnostic radiology in trauma, we'll start with liver and splenic trauma. So this is the American Association of Grading, AASC grading, with 2018 where it was revised in 2018 to include vascular injuries in the grading of liver and splenic traumas. So these grades are available online. So it's not imperative that you have to memorize all these gradings. So based on the depth of lacerations ranging from 1 centimeter to 1 to 3 centimeters and more than 3 centimeters, and presence of subcapsular hematoma, which was previously measured on the basis of depth, but currently it is measured on the basis of the surface area covered by the subcapsular hematoma, and also on the basis of intraparenchymal hemorrhage within the spleen based on the size. Coming to the recent additions in the revised AAST grading, the presence of vascular injuries such as pseudoaneurysm, AV fistula, or an active extravasation contained by the splenic parenchyma is given a grade of grade 4. In addition, with the previous grading of more than 25 to 75% devascularization of the splenic parenchyma. And in addition, so whenever these vascular injuries are not contained by the splenic capsule and there is active extravasation into the peritoneum, or when it is a shattered spleen, it is given a grade of 5. So moving on to the liver injury grading in blunt trauma abdomen, again, the depth of laceration here is gauged by the same 1 centimeter, 1 to 3 centimeters and more than 3 centimeters. However, the intraparenchymal hematoma we saw in spleen was based on less than or more than 5 centimeters. Here is less than or more than 10 centimeters. And here again, the subcapsular hematoma has the same grading of less than 10%, 10 to 50 and more than 50% of the surface area. And here we don't use the depth of the subcapsular hematoma. So the recent additions again here includes vascular injury, the same pseudoaneurysm, AV fistula, and active extravasation. If it is contained by the capsule, it is grade 3. In spleen, it was grade 4. In liver, it is grade 3. And when it is not contained by the capsule, or there is free bleeding into the peritoneum, it is called as grade 4 parenchymal disruption. And whenever there is more than, whenever there is 25 to 75% of hepatic lobar disruption, that is to say to involve 1 to 3 coinoid segments in a given lobe, means there will be grade 4. However, if there is more than 3 coinoid segments or more than 75% of the hepatic disruption in a single lobe, it becomes grade 5. And also juxtacable and central major hepatic vein extension of lacerations is also considered as grade 5. This is important because juxtavenous extension, this area of liver is the bare area of liver. There is possibilities of bleeding from the IVC, and these bleeding will happen into the retroperitoneum. And we saw that ultrasound or FAST is not a good modality to pick up these bleed, and they can keep on increasing slowly, progressively. And a repeat EFAST may not show hemoperitoneum, but the patient may go in for hemodynamic instability. Okay, so let us, we have seen the diagrammatic representations. Now let's move on to actual cases showing these findings. So we'll look at the findings separately and not at the grading, the different grades of injuries, because that can be graded by anybody. We just need to know how to pick up these findings. So this is the case of subcapsular hematoma. So whenever the hematoma is subcapsular and is contained, it will cause scalloping of the liver margins or the splenic parenchyma. So this suggests that it is a subcapsular hematoma. However, if we see fluid around the liver without causing any scalloping, that would, or around the spleen without causing any scalloping, that would mount to an intraperitoneal bleed. Now, a laceration is typically described as linear branching hypodense non-enhancing areas, as can be seen in this liver parenchyma and in this spleen. And here we can see extension of one of the lacerations to the juxtahepatic and juxtacaval location in this case. And then intraparenchymal hematomas are tricky to diagnose because there is a constant confusion with parenchymal contusions. However, you can see that the intraparenchymal hematomas are usually a little hyperdense, and more often than not, there will be surrounding lacerations which will be extending. So more commonly, it is a case of
email அடிச்சா மதியா
we can see normal blood vessels or enhancing blood vessels coursing through the contused parenchyma, because the parenchyma is injured and edematous, but the parenchymal architecture is maintained and the vessels are maintained. So coming to devascularization that we had looked at, hepatic devascularizations are very rare phenomena because of the presence of dual supply. So even if there is a cutoff of the hepatic arterial supply, the portal venous supply, which constitutes 70% of the oxygen supply to the liver parenchyma, is sufficient to maintain hepatic oxygen supply and prevent any infarction. However, as we can see in this case, if there is a disruption of hepatic artery and portal vein, in this case it was a disruption of the hepatic artery with the thrombosis of the portal vein, the patient can have these rare incidences of hepatic devascularization. And here we can see a non-enhancing splenic parenchyma. There is no surrounding hematoma. So this is a case of splenic devascularization. So coming to the vascular injuries that have been included in the recent AAST guidelines. So here we can see a case of active extravasation, seems to be contained by the liver capsule. So there's a hepatic parenchymal hematoma into which there is an arterial bleed. And here is a splenic injury which is contained by the splenic capsule, and there is extravasation. So this is the arterial phase. This is as we saw in the last case, active extravasations are usually indefined, whereas pseudoaneurysms are well defined and often round or oval. And active extravasations can be commonly seen as a jet of linear contrast jetting out from the arteries, and in subsequent delayed scans, they will show layering. However, layering is not a definitive point to diagnose active extravasation, because as we saw in the previous case, even pseudoaneurysms can show layering in cases of narrow neck pseudoaneurysm, and the flow is not very high. And their intensity parallels that of the nearby blood vessels. So this is a case of delayed vascular complication. So it's not in the acute setting, the patient just had a laceration. So these delayed vascular complications are a consequence of, let us say there was a laceration, hematoma, there was an arterial injury, but what happened is the hematoma caused tamponade effect and prevented the artery from bleeding. However, when the hematoma is going to get lysed over 3 to 7 days, these arterial extravasations can start manifesting, and usually are seen as this pseudoaneurysms. So these are delayed pseudoaneurysms. Here you can see the yin-yang phenomenon. In this patient who just had a laceration, in the initial CT there was no pseudoaneurysm or active extravasation. However, 10 to 15 days later, the patient presented. We'll see this case in detail later on in the slides. So MRI in hepatic trauma is rare. It's usually done to look for biliary injuries, as we can see in this case. So these type of biliary disruptions are usually a consequence of lacerations extending to the porta. So lacerations extending to the IVC can cause retroperitoneal hematomas and can complicate the patient in the acute setting. And lacerations which extend to the porta hepatis can cause biliary injuries and biliary strictures later on. So now moving on to diagnostic radiology in trauma to pancreas. So the pancreatic injury in blunt trauma abdomen is relatively rare. The mechanism of injury usually being compression against the vertebra wherein the body and neck, since they are in close contact with the vertebra and anterior to the vertebra, they are the most commonly injured areas, as unlike the head and a high index of suspicion has to be maintained while evaluating pancreatic trauma. NDCT, in the initial CT, low-grade injuries of pancreas are usually difficult to pick up. That is because pancreatic injuries are best picked up in the pancreatic venous phase. However, we acquire the early arterial and the portal venous phase. So in such a setting, to pick up the pancreatic injuries in the portal venous phase is quite difficult. And these patients will usually progress and present later on with features of pancreatitis because of exudation of the pancreatic enzymes into the surrounding parenchyma. And CT has a poor sensitivity for confirming or picking up ductal injuries. Moving on to MRI and MRCP, they can be called as a workhorse in detailed evaluation of the pancreatic injury, and they are very good in evaluating the ductal injuries and the surrounding collections which happen as a late consequence. So early diagnosis here is critical, as we have to decide between surgical intervention versus non-operative management. And delayed morbidity, that is when the patient is going to present at a delayed setting, we'll see the cases how it becomes more complex to treat. So this is the AAST grading for pancreatic trauma with mild contusion and minor lacerations without duct injury being grade 1, major contusions or major lacerations without extension to the duct being grade 2. Grade 3 injuries are those with ductal injuries or having distal transection. Proximal transection and the parenchymal injury involving the ampulla amount to grade 4. And grade 5 injuries is severe disruption of the pancreatic head. Now we'll see a few cases. So here we can see that the pancreatic parenchymal margins are maintained, and within the margin you can see a non-enhancing area. So this is a case of minor contusion of the pancreatic tail. And here we can see a major contusion involving the pancreatic injury. And however, here we cannot differentiate based on CT whether it is causing any duct injury. So an MRI is warranted in this case. This is a case of distal transection of pancreas. So how do we decide what is the distal transection and what is the proximal transection? So distal transection is any transection to the left of SMA, and proximal transection is anything to the right of SMA. Because that would decide whether the patient goes in for a distal pancreatectomy or a total. And then moving on to the disruption of the head of pancreas, here we can see a case of severe disruption of the head of pancreas, and these patients will usually have to undergo a Whipple surgery. And here we can see a case of pancreatic contusion, which is hardly picked up in the portal venous phase of this patient. However, when we do an MRI, we can see a full thickness laceration of the pancreas with oozing of a pancreatic duct with ductal injury. So this is a partial thickness laceration of the pancreas, which can be seen here, and this is a case of contusion of the pancreatic parenchyma. Coming on to the complications. So every complication that is associated with pancreatitis can be seen in pancreatic injury. So we can see large pseudocysts. So these pseudocysts can become so large, and they can undergo automatic decompression by forming fistulous communication with the gastric lumen, with the colonic lumens, etc. And however, these abscesses these pseudocysts can also undergo infection and form abscess, and they can even have vascular complications, which is usually, as seen in pancreatitis, a case of thrombosis of the splenic vein, or there can be pseudoaneurysm of the arteries in the surrounding the pancreatic parenchyma. So these were direct signs that we have seen. However, there are some subtle signs which can help in aiding the diagnosis of pancreatic injuries. So the presence of fluid around SMA, which cannot be explained by any other associated injury, is then you should have a high suspicion, a high index of suspicion for pancreatic injury, and the patient should undergo an MRI. And similarly, thickening of the left renal fascia, which is not explained again by any other focal trauma, then again that has to be evaluated with an MRI. Here we can see the presence of peripancreatic fluid and also fat stranding in the transverse mesocolon. So these are some secondary signs which can aid in picking up pancreatic injury, and these patients must be evaluated with an MRI. So moving on to the role of interventional radiology in trauma. So the prerequisites of interventional radiology being a part of abdominal trauma requires that we have a 24-hour access to the IR suite and the IR team who are ready to intervene within 16 minutes of deciding on the treatment management. We should have a good anesthesia support who can manage the cardiovascular status of the patient, and we need a multidisciplinary team which makes a decision of whether the patient undergoes an intervention, radiology, or a surgical intervention. So the role of IR in acute abdominal trauma is to achieve rapid control of exsanguinating hemorrhage, which requires a balance between precision versus suboptimal embolization, which we will see subsequently, and also a crucial decision between proximal versus distal embolization. So these are for to block vessels. However, if you want to maintain for peripheral vascular and aortic vascular injuries, covered stents play a crucial role. So these are the SIRs, Society of Interventional Radiology Standards of Practice recommendations. So all departments with IR for abdominal trauma should have an evidence-based treatment algorithm for managing patients with abdominal trauma. And there has to be separate algorithms for pediatric patients. For liver interventions, non-operative management is the new norm in hemodynamically stable patients, predominantly in grade 1 to 3 injuries, and also in a few selected cases of grade 4 and again, non-operative management is the norm in grade 1 to 3 injuries. Non-operative management plus embolization is the SIR practice recommendation, standard of practice recommendation for grade 4 to 5 injuries where the patient is hemodynamically stable. In pancreas, the role of intervention radiology is usually not in the acute setting, but rather in managing the complications of pseudocysts, abscesses, and pseudoaneurysms developing later as a consequence of pancreatitis. So let's have a look at the embolizing agents that are commonly used. So if we can achieve superselective catheterization, and it's an end artery such as the renal arteries, we can go for coil, which is an embolization agent of choice. Rarely, glue can also be used. Problem with glue, we'll see it subsequently. However, whenever there is good collateral circulation, such as in liver and splenic injuries, there needs embolization, both proximal and distal to the bleeding side, when we can achieve superselective catheterization. So if there is an injury to a major artery such as aorta or subclavian and peripheral vasculature, then we have to go for a covered stent to preserve the distal vascularity. However, in cases of bleeding where we have not achieved superselective catheter, whenever the perfusion pressure decreases, there is more chances of the a proper hematoma forming before getting washed out by ongoing bleed, and this hematoma can have a tamponade effect and prevent further bleeding. So here we use larger size coils because we'll be doing a proximal embolization in larger caliber vasculature, or we can sometimes even go for occlusion devices such as amplatzer vascular plug. Distal embolization can usually be done whenever there is superselective catheterization is still not possible by way of gel foam and using of non-absorbent particles, which are usually usually used rarely. So coils and gel foam embolization are the workhorse of interventional radiology in trauma. So the embolizing agents which are not commonly used in vascular injury are powdered form of gelatin sponge. So these minute powdered forms can cause obliteration of the small caliber vessels. This is especially problematic in splenic parenchyma. So the main concept of proximal embolization in splenic parenchyma in grade 4 and 5 injuries is to maintain, if the patient undergoes a splenectomy, the patient is going to have a compromised immune status for the rest of the patient's life. So the non-operative management of these injuries is critical in hemodynamically stable patients, and therein comes the role of IR. So whenever we do a proximal embolization, the collateral circulations take over. However, the perfusion pressure is reduced. So there is perfusion, but there is no infarction. So that is the concept of proximal embolization in splenic trauma. When we use the powdered gelatin foam, these are going to block the distal vessels supplying the splenic parenchyma, and these parenchyma will undergo infarction. So we usually avoid usage of fine powder form of gelatin foam, gelatin sponge in splenic trauma before coil embolization. And also use of PVA and liquid embolic agents are rare in trauma. In patients of trauma because of the difficulty in handling, and there is a high risk for non-targeted embolization. Alcohol is very rarely used in trauma patients, or let's say it's not used in the current setting. So whenever these trauma patients can have coagulopathy, they could have undergone multiple blood transfusions, and there is usually a coexistent coagulopathy. And in such patients, embolizing agents such as gel foams and coils, which are the workhorse in IR and trauma, are not much effective because they require an intact coagulation mechanism for a clot or a thrombus to form around them and reduce the distal perfusion. So in these cases, we can go for glue or onyx, which can be used. Again, they will have their own disadvantages of non-target embolization. Hydrogel coils are a recent addition. These are platinum coils coated with expandable polymers, and they increase in volume by up to 9-fold once deployed, and when they come in contact with the surrounding fluid. However, they are costly, and there is a possible chance of blockage in incompatible delivery systems. So you will require a proper delivery system for these coils, which adds to the cost. Now let's look at a few case illustrations. This would be the last segment of my presentation. And these images, and you would have observed in most of my images, have been taken from the Department of Radiodiagnosis at the Trauma Center, AIMS, New Delhi. And again, these images, this is an article published by the Department of Radiodiagnosis. Since most of my experience in trauma interventions is from this institute, I have taken permission and displayed, for displaying, sharing these images. So interventional radiology in liver trauma will start with active extravasation. So here we can see that the patient has a liver trauma, and there is a focus of active extravasation in a patient with grade 5 injury. And the DSA showed the presence of active extravasation, which in the delayed phase is continuously increasing. And then we have embolized the anterior division of the right hepatic artery selectively. We can see the rest of the branches of the right anterior division of the right hepatic artery, which is showing the enhancement of the normal parenchyma without any active extravasation. And this is a case of pseudoaneurysm. This blob of pseudoaneurysm can be seen here. However, when a angiogram of the left hepatic artery is taken, we cannot visualize the pseudoaneurysm. A replaced right hepatic artery was seen in an SMA run, and this was selectively embolized. So we couldn't we couldn't cross the pseudoaneurysm, neck of the pseudoaneurysm, because of the spasm. And so we did a proximal embolization, and then there was no opacification of the pseudoaneurysm post-embolization. Now, this is a case of prophylactic embolization in a patient with grade 5 splenic injuries and laceration, a grade 5 injury, wherein there is involvement of more than 75% of the right lobe. There is no active contrast extravasation or pseudoaneurysm. However, the patient was hemodynamically stable, and hence, considering the grade of injury and a preference for non-operative management, we went ahead and did a gel foam embolization of the hepatic artery, showing no opacification of the distal branches. So here we can see another aspect of interventional radiology in liver trauma, which is re-bleed after packing. So let a patient is hemodynamically unstable. Patient went in for a damage control surgery, and a perihepatic packing has been done, which can be seen here. These are the gauze, which can be seen in this damage control surgery, and still the patient is hemodynamically unstable. So since we know the organ which is injured, as it has been found out during the surgery, we can go ahead and directly cannulate the hepatic artery and no need for a CT angio. And here hepatic artery cannulation shows this pseudoaneurysm arising from the posterior division of hepatic artery. So we are able to cross the neck of the pseudoaneurysm and we have embolized both proximal and distal with the sandwich technique, and we have isolated the pseudoaneurysm. And the post-procedure scan, the angio shows non-opacification of the pseudoaneurysm. So delayed pseudoaneurysm, the case that we have seen, there was lacerations, hepatic laceration in this patient, managed conservatively. In the acute setting itself, the patient had hypertense contents within the GB. So we suggested a possibility of hemobilia. However, the patient since patient did not have melena and was hemodynamically stable, the patient underwent non-operative management. Patient was good to go, was discharged. However, the patient presented to emergency department 3 days later with 2 episodes of melena. And we did an ultrasound, and this showed this typical yin-yang phenomenon, showing the pseudoaneurysm, which has developed in the delayed setting, probably because of the lysis of the surrounding clot, and the artery started bleeding into the pseudoaneurysm, into the cavity, forming the pseudoaneurysm. And this was embolized, and this is the post-procedure ultrasound showing echogenic thrombus in the pseudoaneurysm. A microcoil embolization was done. Now moving on to splenic trauma and interventional radiology. So here we can see focal contrast extravasation, which is increasing. This is the same patient we had seen with splenic parenchymal hematoma with surrounding laceration. There was contrast extravasation, and a diagnostic angio showed multiple foci of contrast extravasation. So a distal embolization was not feasible, and we have embolized. We have done a proximal embolization. Here you can see the coils being deployed, and there is no opacification of the distal splenic artery. So again, the coils are usually placed after the takeoff of the dorsal pancreatic artery and before the origin of the arteria pancreatica magnum. So this forms a collateral circulation which can perfuse the splenic parenchyma. However, in cases of pseudoaneurysm, this will not suffice because this pseudoaneurysm can rupture at any point of time. And as seen in this case, there is a focal vascular outpouching, which is showing contrast matching with the aorta. And here, splenic angiogram shows, splenic artery angiogram shows a pseudoaneurysm, which is leaking. So this is a leaking pseudoaneurysm. And in this case, we have gone distally and embolized the upper polar artery, which was supplying the pseudoaneurysm. And then we can see the normal enhancement of the lower polar branches. So to conclude, proper grading of intra-abdominal solid organ injuries is imperative in guiding management protocols. All trauma CTs should be viewed after understanding the mechanism of injury so that you can pick up even the subtle findings by having a high pretest possibility. And pancreatic injuries especially require a high index of suspicion to diagnose on CT and take up these patients for MRI. Prompt IR intervention can reduce mortality and morbidity in a lot of patients and aid in a success of non-operative management, which is a new norm in managing solid organ injuries. And a definite protocol should always be followed for interventional radiology in trauma. I would like to thank my professors from whom I've learned most of my trauma interventions, or let me say all of my trauma intervention, and also my seniors who have aided me in acquiring these images. So that is the end of my presentation. And I thank you all for your patient listening.